Today on Diabetes Connections Type 2, medications like Ozempic, Wegovy, and Mounjaro have exploded into the headlines. Well, what actually are they? How do they work to help people with diabetes? And should you think about taking one? Plus, we'll break down the difference between Type 1 and Type 2. I get this question a lot, so let's explain it. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. I went to a diabetes conference earlier this year, and I saw something I knew I needed to tell you about. It's called CeQur Simplicity, and it's a game changer in insulin delivery. It's like a wearable insulin pen, a patch that's water-resistant, thin, and lightweight. Best of all, it seamlessly fits into your lifestyle. For many of you, remembering your supplies or the hassle of injections is a daily challenge. Now, you can say goodbye to mealtime injections. With CeQur Simplicity, you only fill what you need for 3 days, and it can be worn discreetly under your clothing, making dosing a breeze. If you're on long-acting insulin, you'll still take that shot once a day, but your mealtime insulin will always be with you. Find out more, go to clickinsulin.com. That is clickinsulin.com. Hello and welcome to Diabetes Connections Type 2. I am your host, Stacey Sims. And for a very long time, more than 8 years now, I've hosted another podcast for people who live with Type 1. But for a while now, I've been thinking we need something like that for the Type 2 community. So I've started what's going to be a short run, probably about 8 episodes. And then if you like it, we're going to keep going. My background is in broadcasting. I spent my career in radio and television news. I started Diabetes Connections, the other podcast, back in 2015. My son lives with Type 1. My husband lives with Type 2. I do not have any type of diabetes. But as I said in the first episode, the idea here is to provide information without, nagging or lecturing. But there's a lot of data with diabetes, and there's quite a bit that I find endocrinologists and general practitioners kind of assume that you know. And I learned with both my son and my husband that we didn't know what we didn't know. And that included a lot of basics. So I decided to add just a minute of diabetes education to each episode to give you some facts and some data that might have been overlooked. So this week, I want to explain the difference between the two main types of diabetes. There are a lot more types, but we're going to save that for another time. So Type 1 used to be called juvenile diabetes, but you can develop it at any age. In fact, half of all new cases are in people over the age of 25. Type 1 is an autoimmune condition in which the body stops making insulin. Type 2 diabetes used to be called adult onset. It's where the body produces insulin, but the cells don't respond the way they should. That's insulin resistance. So with Type 2, on top of that resistance, the pancreas often has trouble making extra insulin. So, we tell kids that food is our body's fuel, and that's true, but here's how it actually works. All food is broken down into glucose, which eventually makes its way into the bloodstream, and then the body's cells where it's used to create that energy we all need. Insulin comes into play here at the cell's entrance. A lot of people describe insulin as the key that opens the cell's doors, letting the glucose inside. So when you have diabetes, glucose builds up in the bloodstream, causing your blood glucose, your blood sugar, to go high, and that can cause damage to various parts of the body over time. Most people with Type 1 need to start injecting insulin as soon as they are diagnosed. It cannot be controlled with diet and exercise alone. With Type 2, in its early stages, it is often possible to control with diet and exercise. But over the course of Type 2, particularly when it's not managed well, the body stops being able to make enough insulin to force its way into the cells. And when this happens, people with Type 2 also need to start using insulin. It's worth noting that even some people who manage their Type 2 exactly how their doctors would like end up using insulin. This usually happens to people with a very strong genetic history. I'd compare it to how some people eat a healthy diet, but still need to take cholesterol-lowering medication. So it's not always about management. So the stigma about using insulin really shouldn't exist. This information comes from the Joslin Center, and I will link it up in the show notes for this episode. Okay, up next, let's talk about Ozempic and Mounjaro. You're going to hear from Dr. Steve Edelman, who heads up Take Control of Your Diabetes, that is TCOYD, a not-for-profit with the goal of teaching and motivating patients in diabetes self-care. This is a great group. As you'll hear, they use a lot of humor. Dr. Edelman is an endocrinologist who lives with Type 1. We're going to go through the science behind these drugs, who might think about taking them, and whether they live up to the hype. Quick note here, in the time since I talked to Dr. Edelman, there have been some new findings about what else these drugs can do. So I'm going to come back after the interview and give you a quick update. As you'll find out, I'm a huge fan of choice when it comes to diabetes technology. We've come a long way since my son was diagnosed in 2006. And you want a medical supply company that can provide what you want. That's why I'm so excited to partner with US Med. They have whatever you need. They hold the #1 spot as the distributor for Freestyle Libre systems nationwide. They rank #1 in Dexcom customer surveys. They're the top specialty distributor for Omnipod Dash and the fastest growing tandem distributor nationwide. US Med always ensures you have 90 days worth of supplies and provides fast, free shipping to your doorstep. Plus, rest easy knowing they hold an A+ rating with the BBB. US Med, your trusted partner in diabetes care. Your health, satisfaction, and peace of mind are their priority. Find out more. Go to usmed.com/Stacey. That's usmed.com/STACEY. Dr. Steve Edelman, thank you so much for joining me. I have to admit, I'm a little intimidated by this topic. The names alone, I feel like, are going to throw me, but I really appreciate you spending some time to kind of go through this with me. Thanks for joining me.
Stacey, thanks for inviting me. I took a special English course how to pronounce some of these crazy drug names.
Well, the names may be bananas, but the results really seem to be very good. So before we jump right on in, let's talk about how these work. I don't know if we should go through them one by one or talk about categories perhaps, but we're going to be hearing words like semaglutide and GLP-1. Can you do some definitions for us first?
Yeah, well, I think we can bunch them all together and call them the group of GLP-1, ready for this, receptor agonists. So let me just describe what GLP-1 is. Glucagon-like peptide 1 is a natural hormone in our bodies that's found to be deficient or does not work adequately, especially in people with type 2 diabetes. We can talk about type 1 a little later. And the reason why these drugs are called RAs, receptor agonists, because they are not the actual GLP-1 drug themselves. They are medications that stimulate the receptors on cells that make natural human GLP-1. So it's a way that we address certain conditions that are short or limited in certain hormones that are important. So the GLP-1, we'll just say GLP-1s for now, it's just easier. A class of medications, believe it or not, Stacey, the first one approved in 2005. And that was called Byetta. And it was also called exenatide. You know, all these drugs have the chemical name and the marketing name. And all of these GLP-1s end in tide, semaglutide, liraglutide, the Lilly product Trulicity, which is, now I'm blanking on it myself, but the marketing name is Trulicity, dual glutide. There it is. They're all under the class of GLP-1s. Now, through the years, the first one, Byetta, you had to take it twice a day. Then they developed, they being the people from Amylin Pharmaceuticals, they don't have the medication anymore. It was now owned by AstraZeneca. They figured out a way to make it once weekly. Then jumped into the game with Novo Nordisk, had the once daily, many know the word Victoza. And then they came up with Ozempic, which is once weekly GLP-1. That's semi-glutide. So it's not the same, even though it's the same company. You take it once a week, and then Lilly jumped into it, and they got Trulicity, which is once a week. And then we should save the discussion for Mounjaro after we get through with the GLP-1s. But Mounjaro, made by Lilly, has a GLP-1 plus another receptor agonist. So it's a combination of two. But the bottom line is they've improved in their, for lack of a better word, kind of a doctorish, pharmacokinetics, where you can take it once a week. The different pens are a little bit different, easy to deliver. But very importantly, if someone's a type 1 that's on these drugs, you can titrate them yourself and go much slower than the recommended starting dose. I don't want to get too ahead of ourselves.
Yeah. Let's save the type 1 discussion for a couple minutes and the Mounjaro discussion as well, because those are both really important. But back to the semaglutide, when you say, it was first around in 2005, this may be a really dumb question, I assume more has changed than just a once weekly dose because it seems like people are saying it's working so much better.
Okay, that's the best question I've ever heard regarding this topic. Okay, the answer is they have not changed. What has changed is our society's medical profession to accept these drugs as really making a serious impact.
You've got to be kidding me.
No, because the package insert, for the listeners, that's the list of side effects and effects of these drugs. And it's basically the same. Now, the one thing that has changed is that they did these, thanks to people that were pushing back at these medications, saying they were dangerous from the heart. These companies had to do these very long, very expensive, and extensive, what we call cardiovascular outcome trials. In a nutshell, they gave like 10,000 people either a fake pill or, let's just say, Ozempic. And they measured things over time, especially cardiac things like heart attack, stroke, death due to heart disease for any reason. That's what they called these outcomes. And what shocked everybody, just shocked them beyond belief, they were looking for bad stuff and they found tremendously good stuff. Mm-hmm. So when you look at the indication for, let's just say, Ozempic or Trulicity, both of them, they're indicated for the treatment of type 2 diabetes, and they have the official FDA sanction that they reduce the incidence of heart attacks and strokes. That's new, but the medication themselves are not new in any way. The formulation is different. Obviously, once a week is better than twice a day.
Sure.
But Stacey, these drugs were hardly used for 10 frickin' years. Could I say that on your...
You can say whatever you want.
Yeah, well, lucky it was frickin'. And guys like me, other endos, they thought these drugs were so impressive. When a drug is first released, there's a lot of baggage that come to it. People don't, there's a lot of naysayers. Well, it may cause this, may cause that. And in fact, there was one black box warning, I'll explain that in a second, that was on Byetta, the very first GLP-1, and it's on every single GLP-1 today. And the black box warning is that it can cause pancreatitis. And actually, the first big black warning is if you ever read a label, it can cause thyroid cancer, a certain type of super rare thyroid cancer, medullary thyroid carcinoma. So guess what? When you give it to rats in 100 times the physiologic dose, they saw it. Has any of my colleagues ever seen it in humans? Have I ever heard someone speak about a real case in humans? No. But once something gets on at the label. So you can imagine this, a brand new class of drugs, Byetta, and it has this black box warning about medullary thyroid carcinoma as part of ready for this, MEN type 2, multiple endocrine neoplasia type 2, all this medical, alphabet stuff. It got off to an extremely slow start, Stacey, even though the very first medication, Byetta, caused weight loss. And that's one of the big benefits of the medications today. And that's why all these frickin' movie stars are taking our Ozempic for our patients. And that's why there's a shortage.
Yeah.
3-4 months. And, people are using it in health clinics. And I'll tell you, I don't think there's any better way to approach weight loss than one of these GLP-1 drugs because they're stimulating a receptor that secretes a natural hormone, super safe, and no surgery required. And you can get weight loss very close to what you see with bariatric surgery.
It is incredible to think that an injection could have the results of bariatric surgery. Can you talk a little bit more about how that's possible? How does it work?
Yeah. Okay. Well, basically it works in several areas of the body. When you inject it, it does several important things. First of all, it goes to the gut and it stimulates your whole GI tract. First of all, you're going to release preformed GLP-1. Then you're going to slow down gastric motility. Now, why is that important? Because most people with type 2 diabetes have hypermotility. So think about this. If you eat something and it dumps all the nutrients in your stomach where the food gets digested into the small intestine, it gets absorbed quicker. So the first thing it does it slows down gastric motility. So less nutrients go to the small intestine, less nutrients are absorbed in the systemic circulation. And so your post-meal blood sugar is markedly blunted, which is what you want. when you have diabetes, right?
Yeah.
It also goes to the liver and suppresses what we call hepatic glucose production. A big problem with type 2s is that their liver overproduces glucose inappropriately. So it suppresses that. Then it actually goes to the brain and induces, and this is where the weight loss comes in, it induces satiety. What does that mean? It means that when you start to eat a meal, you get full faster. And it's a little different than reduce your appetite, which is you're not even hungry in the first place. So it turns out that the brain is a big black box. We don't know what goes on in the brain, but we do know that these medications consistently lead to, and if you're a doctor, you're gonna look for these phrases, statistically significant weight loss, meaning that when you do a formal study, it didn't happen by chance. Every single drug in this class, GLP-1, has led to statistically significant weight loss compared to placebo. And when you talk to patients who are on it, people who are on it, they'll tell you, yeah, it really knocks out my appetite. And other people will say, you know what? I always have to get a doggy bag. I might sit down to a meal ready to eat everything in sight, and I get a third of the way through the meal, and you're just not hungry anymore. And that's the beauty of these drugs, Stacey, because you don't need psychological treatment. You don't need to start thinking about, your feelings of when you're full. It happens whether you like it or not, which is why it's so successful.
I have heard some people say that there is some nausea, some stomach upset in starting these drugs. Is that part of the reason why it reduces appetite, or is that something that most people kind of get through quickly? If your doctor wants you to check your glucose using finger sticks, ask them about using a Dexcom G7 continuous glucose monitoring system instead. Dexcom G7 is a glucose sensor that sits just beneath the skin, allowing users to check blood glucose without pricking a finger. It provides key trends data that gives users and their health professionals the knowledge to adjust diet or medication. Dexcom CGM removes the mystery from diabetes. If you need help talking with your doctor about Dexcom CGM, they've got a great discussion guide to help you get started. Find out more. Go to diabetes-connections.com and click on the Dexcom logo.
That's a great question. They've looked at this every which way. It's not how the drug works. First of all, no one likes to be nauseated. And I don't think these drugs would be successful if it wasn't just temporary. Now, here's how it works. You start off with a low dose. All of these GLP-1s have to be titrated. Start low and go slow. And I think when I start someone on one of these medications, I say, listen, these drugs have been around for well over 10 years. They've withstood the test of time in terms of safety. But if you start off too quickly, you can get nauseated. And some people actually vomit, although it's rare. And that's why we start with a low dose with individuals. And you still can get a little nausea, but typically you don't need any medication like, Zofran, which is an anti-nausea pill. You just need to sort of hang in there until it goes away. And there are ways to get around the nausea too, depending on which type of formulation you pick. Because as I mentioned earlier in the program, the Ozempic, you have to dial your dose. There's clicks, like 20 clicks is the first lowest dose of the 0.25 pen. So for example, if someone's getting nausea, I'll say just click 10 times. There's no rush, Stacey. These people are waiting to get this drug for a long time. I always start with a lower dose. If there's no side effects after the first week, then we can go up normally. But I would say the vast majority of people have no side effects. And we'll get to type 1 later, but type 1s may be a little more sensitive to the nausea.
I just wanted to confirm that it wasn't a weight loss drug that just made you not want to eat because you were sick all the time.
Right. No, that's not it.
That's great. Hey, let's jump into type 1.
Okay.
If we can come back to some other questions, certainly about the type 2 issue.
Sure.
Let's talk about people with type 1 diabetes. As far as I know, this isn't specifically approved for people with type 1, but they can see some benefit too, right?
You're right. Basically, a lot of drugs that are made for folks with type 2 have great benefits in people with type 1. I'll just say real briefly, the class of medications that we haven't talked about yet, or we may not on this podcast, the SGLT2 inhibitors, Farxiga and Jardiance. Everyone's seen the commercials. And those drugs reduce congestive heart failure, but also very importantly, they can protect the kidney from getting worse. And even though they're not approved for type 1, the indication says to reduce the progression of diabetic kidney disease in people with and without type 2 diabetes. So I consider when you have type 1, you are the ones without type 2. So I have chronic kidney disease. Mine's stable. I know everyone's feeling sorry for me right now. And I had type 1 for 53 years, and I do have some kidney issues. And I am on Farxiga myself to help prevent the progression. And it already has shown some benefits at some of the laboratory analyses of my kidney. So getting back to GLP-1, there are a lot of people that feel that the mechanism to reduce heart attacks and strokes that GLP-1s infer upon people with type 2 also can help protect people with type 1. But Stacey, if the drug's not approved, the companies that make these drugs, it's really not in their best interest at all to do one of these large cardiovascular outcome trials, which are super expensive and take years. And if it's not approved, you have to feel a little bit sorry for them that they're not going to make any of their investment back. There are some what we call investigator-initiated studies. These are doctors that don't work for the pharmaceutical company, and they've done smaller studies that you can infer there's some benefit. But also, I would say, Stacey, if you look at some of the data coming out in all of us type 1s, we all get heavier over time. And that's been shown in study after study after study. Why is that? Well, people get heavier over time. And us type 1s are not that abnormal where we're somehow prevented from gaining any weight. And there's been several studies of GLP-1s in helping reduce glucose fluctuations and improving time and range. So when you take the body of literature, it helps with glucose control, especially time and range, and what we call glycemic variability. It definitely helps with weight loss, and that's beneficial for blood pressure, cholesterol, heartburn, fatty liver, which type 1s can get, but mostly type 2. And there's no adverse effects that are specific for people with type 1. So why not? And because they don't have the official approval, it doesn't mean that physicians cannot prescribe them. The official word is if someone prescribes it for you, it's off label, off the FDA label. And that's not unheard of. As a physician, you're supposed to say it's off label, but is it safe and effective for this patient of mine? And if it is, you just document it. You get the patient's buy-in, you document that, and everything is kosher. There's no reason why people with type 1 could not benefit from GLP-1s. I have a lot of patients on it. I'd say primarily for weight, that these folks have gained way too much weight. They've tried every diet in the book, and we start with a GLP-1. We start with a very low dose. We titrate up very carefully. If there's any nausea, we might even go back a step to the previous dose. And I would say this, I can't even remember a patient that did not respond to it. Now, I should say one other thing, Stacey, and I'll let you get a word in edgewise, that this is why my first wife divorced me. I never stopped talking.
I feel like, listen, this is why and we'll talk about it. You have your own podcast. This information is so valuable and you present it so well. I'm just going to try to keep the conversation going. You just keep on going.
Okay. As you and I were talking about before we started, because these drugs are so effective at weight loss, these companies that make them, Novo, Lilly, they went to the FDA and they said, we want this approved for weight loss with or without diabetes or any other condition. The main indication is for weight loss. So they did the studies, very expensive, long-term studies. They statistically proved that these drugs can help anybody that's overweight lose a significant amount of weight, like 10 to 15% of their body weight. So let's pick someone that weighs 200 pounds. 10% is 20 pounds. And that's sort of part of the average. But some of these are up to 15%. That's 30 pounds. And that's not including any other non-pharmacologic effort that people may put into weight loss. So there's 2 drugs that are approved. We talked about Ozempic, which the chemical name is semaglutide. The maximum dose approved for people with type 2 diabetes is 2 milligrams a week. When Novo Nordisk did the studies, they used 2.4 milligrams in the weight loss studies. So that dose was approved. The FDA makes the companies give it a different name, even though it's the exact same molecule, but just in a higher dose with a different indication. And that's called Wegovy, Wegovy. And then the very first Novo GLP-1 that was once a day called Victoza, the chemical name liraglutide, they can make Victoza in a higher dose. And they did the studies, got approved for obesity. And that drug is called Saxenda, Saxenda. And that, once again, has the official indication. So if you have type 1 and your body mass index, BMI, is over 27, and you could go online, type in, calculate BMI, it'll ask you your weight and your height, and it'll tell you what your BMI is. And if you're over 27, then you could be officially approved for one of these two GLP-1s for weight loss. Now, before you get a chance for a question, I got to tell you a funny story. One of our videos that we do at Taking Control of Your Diabetes, I wanted to do something fun with the Saxenda. So I called it Sexenda, S-E-X. And my point of the video, it's like 2 or 3 minutes, was if you lose weight, your sex life is going to be better. And I actually had data to prove it because people do all kinds of studies on everything, a lot of,
Sure.
And so it was a funny video. And then I got called from the folks at Novo and they said, can you please take that down?
Don't do that. I was just going to ask.
Yeah. And so I did. So anyway,
they don't like that.
If you're a type 1 that's overweight, you can get one of these two, the official indication. But once again, if you have weight problems, even if you're at very high risk for heart attacks and strokes, and if your doctor is smart and is nice and knows how to fill out what we call the prior authorization form, you might be able to get it as well.
All right. Let's talk about the elephant in the room. And that is Mounjaro. Am I saying that right? Mounjaro?
Yes. I say it like an Italian. Mounjaro. We have on our TCOID website, we have a lot of, I would say, educational, but also fun videos on Mounjaro. And it's hard to say it every time, so excuse me if I don't.
But I should be clear. I'm not sure I pronounced it correctly, but it is Mounjaro. The N comes first. Mounjaro. Yeah,
it's basically the chemical name is not the easiest to pronounce. Is tirzepatide, and Lilly makes this drug, and it's the combination of two receptor agonist drugs. One is our classic GLP-1 receptor agonist, and the other one's called GIP, and that stands for, you ready for this? Glucose-dependent insulinotropic polypeptide. And that GIP is another important natural hormone. It's important for people to realize this because a lot of people don't want to take, synthetically produced drugs. And GLP-1 is also a naturally occurring hormone. And so what Lilly did is they made up a drug called Mounjaro. It's injectable once a week that stimulates both the GLP-1 receptors and the GIP. Now, it turns out that, it's very hard to separate out how these drugs work in isolation, but because they're all mixed together and work together in the human body in a very sophisticated way to the point we can't even explain it. But it turns out that with these two receptor agonists, that people have lost even more weight than they saw with the GLP-1s, like Ozempic. Now, some of these studies, you're not going to believe it, like people lost up to close to 20% of their body weight. So if you weighed 300 pounds, the average person lost 60.
Wow.
I mean, that wow is right. Now, it turns out that you have to start low, go slow. It's weekly dosing. For an example, you start off with 2.5 milligrams a week, and it takes you like 5 or 6 months to get to the maximum dose of 15 milligrams a week. And you titrate up based on the tolerability. Most people can tolerate it. And when you get to the weight that you're happy with. And I should say this. Now, this is just anecdotal for all the listeners. When you look at the formal studies, they have nausea just like very similar to the GLP-1 alone drugs. But I've consistently observed, and same with a lot of my colleagues, that people have less nausea with Mounjaro than other GLP-1 drugs. However, the GLP-1 drugs are tolerated very well. Now, it's also important to say that at the current time, in May of 2023, the study for weight loss has not been published. So the drug has not been approved by the FDA for weight loss alone. And they might give it another name like they did with Wegovy and Saxenda. And the other study that they're doing that's going to have a significant impact is to get approved for pre-diabetes. And that's mostly pre-type 2. And if they get that approval, there's never been a drug approved for treating pre-diabetes. So we talk about the 30 million people in America with diabetes, most of those type 2. Well, there's another 80 million with pre. So the drug leads to incredible weight loss. So that it's been approved less than a year. And the other thing I should tell you, Stacy, is that the current ongoing cardiovascular outcome trial has not been completed yet, meaning that these other cardiovascular outcome trials with Ozempic, Trulicity, Victoza have all been completed, and the FDA gave them the approval not only to improve diabetes control in type 2, but also reduce heart attacks and strokes. So those studies are all in the works. And if you're a pure scientist, you'd say, well, you can't just say it's most likely going to show benefit. You have to sort of wait and see when they look at the placebo group, heart attack, strokes, and the group that actually got Mounjaro. So there's a lot of big studies that are, I would say, coming near completion. In the next couple of years, you might have an indication, the cardiovascular, and you might have the pre-diabetes, and you might have the obesity indication as well. And lastly, when you look at the package insert again, that's the prescribing information that doctors look at, or I should say we use to fall asleep, stronger than Ambien. It does have the warning black box, risk factor of thyroid C-cell tumors. Same exact warning on every single one, because it contains a GLP-1 receptor agonist as part of the combo. But it's one medication that stimulates both receptors. And you're right, Stacy, it is an impressive compound.
I just want to make sure I'm not missing something with the pre-diabetes studies. Is it working by decreasing A1C? Is that how they decide that it can be used to treat pre-diabetes, or is there something else going on there that's different that happens in people with type 2?
Yeah, that's a great question. The FDA just goes by the A1C criteria between 5.7 and 6.4. But, look, Stacy, the way I look at type 2 diabetes, that's a big part of my career. Some physicians do only type 1, like my good friend and colleague, Jeremy Pettis. It's all part of a continuum. So it's not like you go along, you have central adiposity, you got high blood pressure, abnormal cholesterol levels, and, your A1C is 5.6 and you're normal. And then you cross over to 5.8 and all of a sudden, you got pre-diabetes. It's all part of a continuum. And what goes along with type 2, and that's not anybody's fault, that's the nature of the condition. You got central adiposity, most of the weight around the stomach area. You got high blood pressure. These are all part of the metabolic syndrome. You got high triglycerides, low HDL, which is not good. That's a protective one. You're more susceptible to clots, what we call hypercoagulable state. Those lead to heart attacks and strokes. And then, of course, since type 2 is associated with being overweight, then you got arthritis, you got fatty liver, you got gastroesophageal reflux disease or heartburn. There are higher incidence of certain cancers that occur in the face of obesity. So type 2 diabetes is associated with so many different conditions. And when you have pre-diabetes, you're on your way to getting every one of those if you haven't got them already. But that is what your question was, excellent. And it probably does help every other part of metabolic syndrome. But the FDA strictly goes by A1C.
Got it. Steve, I'm going to say I'm asking for a friend on this question. We mentioned at the beginning, kind of as a joke, the movie stars who take Ozempic. But, I am a middle-aged lady. I weigh more than I did when I was a teenager. I do not have prediabetes, knock on wood. I don't have any type of diabetes. I look at these medications and I think, should I ask my doctor? I'd like to lose, 20 pounds or maybe more. Are we getting to the point where somebody who is, knock on wood, very healthy, I don't take any medication for blood pressure or cholesterol or anything like that, but I'm a middle-aged, heavier lady.
Yeah.
Can I take this stuff?
That's your friend?
That's my friend. Sorry. Yes. Can my friend take this stuff?
Well, I think that the official prescribing guidelines, if you don't have any risk factors, BMI over 30. So it really depends on your height and your weight.
Right.
And I would say this, if your friend doesn't have any other serious conditions like family history is considered, family history of heart disease, personal heart disease, other serious conditions associated with weight, no pre-diabetes. If the BMI is 30, then you should be able to get the medication. Now, let's just say you want to lose 20 pounds, but your BMI isn't over 30. Then it might be difficult to get the medication. Now, not impossible.
I guess what I'm asking is the BMI is, let's give you a made up scenario. The BMI is 27. The person wants to lose 20 pounds. It's not a question of can they get it, should they get it? Are there adverse effects? Are we going to see problems with that kind of stuff?
No problem. No problems with adverse effects at all.
Wow.
Why should there be, Stacey?
I don't know.
They might. No, I mean, the drug works the same. Now, I would suggest this. Well, first of all, you can buy it yourself. And if you live like where I live in San Diego, you can go to Mexico and get it for $30 a month. I got a couple nurses. They're ridiculous doctors at Kaiser did not want to give her the medication. And her BMI is well over 30, it's like close to 40. They wouldn't give it to her. Well, that's a whole different story. And I don't want to start cussing on your podcast.
I appreciate that.
And she buys it herself. If someone is of means, they could buy it themselves. And if they look around, they might be able to get it at a cheaper price, but it's not cheap. But I would say this, putting all that aside, then it is perfectly safe to lose 20 pounds. Now, I had a woman, I'll just say this real quickly. She was kind of pushy and she wanted to lose 10 pounds for her son's bar mitzvah. And I said, listen, this is not what the drug is made for. Because she really wasn't that overweight, but she wanted to look good in her bar mitzvah dress. And I said, please don't ever say that to another doctor if you ever want to get it. So tell your friend that she
sounds like my friend.
Tell your friend that she can ask her doctor that she'd like to lose at least 30 pounds. She feels really heavy and she doesn't feel, she's tried every diet in the book and she feels like it's hurting her health, and if she has heartburn, knee pain, all of that is good to say. And I'm not telling her a lie, but sometimes it's, if you say that, it's not going to hurt.
Interesting. All right. Well, I appreciate the honesty there. And then before I let you go, you mentioned, and I knew this, you've lived with type 1 for more than 50 years.
Yeah.
You're very open that, you had already mentioned you have some complications, but man, you're doing great, Steve. Do you mind talking a little bit about what you think? You must have been asked this before, how do you do it? What do you think really has contributed to your long-term success?
Yeah, that's you asked good questions, Stacey. I got type 1 when we were just urine testing. I was put on 1 shot a day, and there was no education at all for people with type 1. There was no therapies. There's no A1C test, no glucose meters, of course, no CGM, no pumps, no pens. And I would say this, at a young age, when I got to college, I wanted to become a diabetes specialist and really devoted my whole career to diabetes. And I gave up on physicians for a while, and I switched over to patients only when I started taking control of your diabetes. And I would say being in the diabetes field myself, making it my career, has helped me stay up to date, meet lots of people like yourself, learn from them all the tricks, how to live as best you can with diabetes. And I do have a whole laundry list of complications not because I did everything wrong. It's just that I was on such a bad therapy. I didn't have CGM. I didn't have glucose meters. But I go to find the best doctor and I try to do the best I can. Luckily, I'm hanging in there. And my good friend Jeremy Pettis, who also has type 1, he's a great support person along with my family. So that's in a nutshell how to do it.
And I would definitely urge you, and we'll link it up as well, to go to the TCOAD website, not just the videos, which are humorous and educational, but other conferences and virtual events for people with different types of diabetes. It's much more than type 1. You do an amazing job. You don't need me to tell you that. But I appreciate everything you do, Steve. I use your resources all the time. It's helped me so much over the years with Benny. And the humor is much appreciated.
Yeah, that probably has kept me going. Drove my kids crazy. But for me, I have a good time at funerals.
Oh, boy. Well, we're going to leave it there. What an exit. Thank you so much for joining me. I'll talk to you soon.
Thanks, Stacey.
More information about TCOYD in the show notes. I will specifically link up their information about these medications. They have some great articles, advice columns, and some videos, all with that, no lecturing and more humor, which is a great way to educate. I did say I would share more information about the studies that have happened on these drugs since I talked to Dr. Edelman. So let me tell you real quick about that. It looks like semaglutide may have a real benefit for heart health. Wegovy, specifically, which is just Ozempic in a slightly different dose, helped people with heart failure have less shortness of breath, less fatigue, less trouble exerting themselves, better exercise function, and quality of life. This is a scale that they use for people with the most common form of heart failure. The current treatment for people with this kind of heart failure is a diuretic, like a water pill that makes you pee a lot. One doctor in this study said that is woefully insufficient. Another study showed that Wegovy can reduce the risk of heart attack, stroke, or heart-related deaths by 20%. This was a much larger study with 17,000 people. I'm going to link that one up. It is expected that the FDA will expand the labeling indication for Wegovy because of it. As Dr. Edelman said, it's worth noting insurance companies are really digging in their heels and not paying for this all the time. And when they do pay, it can be very tough to find these medications. Please be extremely careful about compounded versions of this stuff. I've seen Facebook ads and local ads. I live in Charlotte, North Carolina, and clinics are popping up where people who, they're not doctors. They're saying, we can mix this stuff for you. Ozempic, no prescription needed. I probably don't have to tell you to be careful about that, but please be careful about that. All right, lots more good stuff to come. I have episodes on the way with some really interesting people living with type 2 diabetes. I'm also talking to the American Diabetes Association about your rights with type 2. We're going to talk about continuous glucose monitoring, all sorts of stuff. Thank you so much to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.
It can be pretty tricky to travel with insulin, especially if you're going somewhere very cold or somewhere very hot. We have found something that really works well for us, and that is the VIVI Cap from Tempramed. It keeps your insulin at the exact right temperature, even in the extreme heat or cold, and it works for any insulin pen. Super simple. You just take the cap off your insulin pen and you slide the VIVI Cap on. No batteries, no charging, no water or ice packs. It lasts for years and gives you 24/7, 365 protection because insulin is very temperature sensitive. VIVI Cap has a 30-day, 100% money-back guarantee, and it's got a 2-year warranty. Find out more. I've got a link in the show notes for you, or you can go to diabetes-connections.com and click on the Tempramed VIVI Cap logo.